All right, let's get straight into it. This is a high-yield clinical review of IgA nephropathy, which you might also know as Buerger disease. We're going to cover the core exam-relevant knowledge that's absolutely essential for your day-to-day practice and for anyone prepping for specialty boards. So let's begin. Here's how we'll tackle this. First, we'll cover the basics, then get into the nitty-gritty of the pathophysiology. After that, we'll look at the classic presentation, nail down the key differential diagnoses, walk through a management plan, and wrap up with prognosis and risk factors. Okay, let's dive right in. To really get a feel for this, let's imagine a classic scenario. Picture this. A 24-year-old guy walks into your clinic. He's noticed visible blood in his urine, and here's the kicker. It started just a day after he came down with a sore throat and a cough. This right here is the quintessential picture we need to unpack. So what exactly is IgA nephropathy, or Buerger disease? Well, believe it or not, it's the single most common cause of primary glomerulonephritis in the entire world. The root of the problem is the deposition of immunoglobulin A, or IgA, right inside the glomeruli. You know, the kidney's little filtering units. Its global prevalence is exactly why it's such an essential diagnosis to master. Now, let's get into the why of it all, the pathophysiology. Understanding the disease mechanism and what other conditions it hangs out with is really fundamental to having a complete clinical picture.
So the disease is really driven by these IgA immune complexes that get stuck in the glomerular mesangium, which then triggers inflammation. Now, this is absolutely critical. This is the exact same renal pathology you see in Henoch-Schönlein-Purpura, or HSP, which we now often call IgA vasculitis. In fact, a lot of people now think of HSP as just the systemic version of IgA nephropathy. If you were to look at a kidney biopsy, you'd see mesangial hypercellularity, basically too many cells in the mesangium. And on immunofluorescence, you'd see it light up positive for IgA and C3 deposits. And beyond HSP, you've got to be aware of some other key associations. IgA nephropathy can pop up secondary to things like alcoholic cirrhosis and celiac disease, which, of course, can also present with dermatitis herpetiformis. So taking a really thorough history for these conditions is an essential part of your workup.
So, how does this patient actually show up in your clinic? Let's circle back to our 24-year-old guy. His story is pretty much the textbook example of IgA nephropathy.
The absolute hallmark is recurrent, visible hematuria. Patients will often describe it as Coke-colored urine, and it typically happens in a young male. But the most crucial clue is the timing. It starts just 1 or 2 days after the symptoms of an upper respiratory tract infection begin. This super short latency period is a key diagnostic feature you've got to remember.
Now, while that visible blood in the urine can be really alarming for the patient, it's the most common sign we see. But it's just as important to know what's uncommon. Seeing significant proteinuria that leads to nephrotic syndrome, that's rare. And having a patient present with acute kidney injury, also pretty unusual. Knowing this really helps you narrow down your differential diagnosis.
This brings us to a super important clinical question, and one that loves to show up on exams. How do you tell IgA nephropathy apart from its main mimic? This is a really common point of confusion, so let's clear it up right now. The key differential here is post-streptococcal glomerulonephritis. Getting this distinction right is a classic test of your diagnostic skills. The best way to think about it is to break down the differences by latency, clinical symptoms, and what you see on the lab work. Okay, let's analyze these key differences side by side. First, latency. For IgA nephropathy, it's just 1 to 2 days. For post-strep, it's much longer, usually 1 to 3 weeks. That's a huge clue. Second, the main symptom. IgA typically shows up with that dramatic macroscopic hematuria, whereas post-strep often presents more with proteinuria and edema, or swelling. And finally, the lab results. This is often the clincher. Complement levels are normal in IgA nephropathy, but C3 levels are characteristically low in post-streptococcal GN. So to sum it all up, that combination of a really short latency period and normal complement levels should make you think IgA nephropathy. All right, moving on to management. The approach here is definitely not one size fits all. Treatment really depends on stratifying the patient's risk of progression, which we figure out using specific clinical and lab markers. So it's basically a 3-tiered approach. For your low-risk patients, we're talking just hematuria, less than a gram of protein in the urine per day, and normal kidney function, we just actively monitor them. For medium-risk patients who have persistent proteinuria over 1 gram per day, the first-line treatment is an ACE inhibitor. This helps reduce that proteinuria and protect the kidneys. And then, For your high-risk patients, the ones with a declining GFR or who just don't respond to ACE inhibitors, we have to escalate to immunosuppression, which usually means corticosteroids. Finally, let's talk about the long game. What does the future hold for these patients? Let's take a look at the prognosis and the factors that help us predict how the disease is going to behave over time. So over a long period, say 20 to 25 years, a pretty significant portion of patients, about a quarter of them, or 25%, will unfortunately progress to end-stage renal failure. And this number really underscores why it's so important to get that risk stratification and management right from the beginning. Now, here's a really interesting clinical paradox. Even though that macroscopic hematuria is the most dramatic symptom, it's actually a marker of a better prognosis. Kind of weird, right? The markers of a poor prognosis are actually more subtle. Things like being male, having persistent high-level proteinuria, we're talking more than a gram a day, and uncontrolled hypertension. And out of all of these, that persistent heavy proteinuria is the single strongest predictor that a patient will progress to end-stage renal disease. So, we've covered the core concepts, all the way from pathophysiology to management. But looking forward, the whole landscape is changing. As new therapies start to emerge that actually target the IgA immune complexes themselves, the big question we're left with is this: could the prognostic factors we rely on so heavily today completely shift in the near future? It's a really critical space to watch.